Okay, we've had a couple of questions in from our people on Facebook and Zoom. And I'll just throw this one, first of all, open to whoever is best placed to answer it. So, given the variety of tests that a patient will go through, what are the key factors that determine what's the right treatment for me?
I guess in standard care, we before anyone starts treatment these days, we do kind of three let's call them fancy tests or molecular profiling, if you like. So one of them is to look at recurrent what we call chromosomal abnormalities. So this is what you might have heard described as FISH, fluorescence in situ hybridization. And there are basically four sort of classical abnormalities, and these are sort of large-scale chromosome abnormalities in the leukemia cells. And there's one of them in particular that is associated with certain things. I'll come back to what those things are. And that's deletion of chromosome 17p. Okay, and the other sort of related test is p53 mutation, and p53 is p53 is a really important gene. All cells have got it, and what it does, the protein product of the gene. So this is the protein that sort of sits inside the cell. It basically does three things. It keeps cancer cells, including CLL cells, in check, stops them growing too quickly, in other words. It also stops more mutations happening, so it keeps the DNA nice and stable, stops other mutations occurring. And of course, if other mutations occur, the disease can change and turn nastier over time. And that's kind of what happens when you have a Richter transformation, for example. And the third thing that it does, it helps certain types of treatment to work, especially chemotherapy that damages the DNA. So it does those three things. So when you lose it, and you can lose it either by not having two copies, and that's what you detect with the FISH test. You lose a copy of this gene because each cell's got two copies. Or if one of the copies goes wrong and becomes mutated. So there's two ways of finding what is essentially the same problem with two different tests. And what the implications of that is that if you've got one of these abnormalities, it means that, first of all, chemotherapy isn't likely to work very well or at all. And in the old days when we were using chemotherapy-based treatment, this was a real issue. And if you found one of these abnormalities, it was such a big issue that you would try and spare the patient exposure to the treatment that you could predict wouldn't work. Now these days that's much less of an issue because the newer drugs don't rely on this protein to work. Okay, they work through mechanisms that don't involve this protein and its pathway. So it's much less important now to find an abnormality in this gene, but it still does have importance even with newer drugs because it tends to go along with disease that grows more quickly. Okay, so it might respond, you might get rid of it as far as you can see, but what's left will tend to grow back more quickly. So if you've got a choice between fixed-term treatment and long-term treatment, you might just be inclined to go for the longer-term treatment because the risk of fixed-term treatment, if you've got one of these defects, is that you might look all right at the end of the treatment, but it will grow back quickly. Okay, whereas a more slowly growing form of disease will take much longer to come back again. So that's one way in which this can be useful. So the other test that we do routine, so that's p53 mutation and chromosome 17p deletion. And the other test we do is called immunoglobulin gene mutation. And you get the result either says mutated or unmutated. And it's upside down because you'd think that the mutated was worse, but actually it's better. And there was a guy who used to have a T-shirt, very happily mutated. It was a great sort of way to remember. And again, the unmutated immunoglobulin gene, if you've got one of them, it means the disease is going to grow back more quickly if you have fixed-term treatment. So you might be inclined to opt for the continuous form of treatment. So in a very long-winded way, I hope that sort of addresses the issue.
Thank you. And I suppose what I should take from that is it's not one size fits all, and it very much depends on the analysis of that test. It seems like new treatment combinations coming through are mainly for patients on their first treatment, while those on their second or subsequent treatment have worse options. Open to opinion, that one. For example, venetoclax and ibrutinib or venetoclax and obinutuzumab are not available for relapsed or refractory disease. Could you comment, please, and perhaps give us hope that NICE and the drug companies will be equally considering the needs of relapsed patients in future?
The majority of our first-line treatments are available for the relapsed refractory setting, albeit in slightly different combinations. So we've got, if you haven't had venetoclax, you've got that as an option in your second-line therapy, either with rituximab or as a single agent. And patients that have started with venetoclax-based therapy have all the options of the BTK inhibitors. And there are ongoing trials and newer BTK inhibitors, the non-covalent BTK inhibitors coming through. So there are good and good options available remaining for patients with relapsed refractory disease, and even kind of newer different treatments to these BTK inhibitors and the venetoclax-based therapies. We have what's called BTK degraders coming through. So it's that process is being looked at for all our patients, I would say.
Okay.
Can I add to that?
Sure. Yeah.
I absolutely agree with what Stella's just said. Just to add that. When you get a new drug on the scene, it's almost always looked at in people that have been treated before it's then looked at in untreated patients. So all the new drugs come in they're looked at in the relapsed refractory setting, and then if they look promising, then they're brought forward to the frontline setting. That's how it normally works.
Oh, that's interesting. Okay. Sometimes when we get questions in, they're based on the individual's own experience, and we know we can't answer that fully because the clinicians who are going to be asked the question don't know the full case history of the patient, and I think this is possibly one of those questions. But here goes. My CLL diagnosis was by phone 2 years ago following tests for a diagnosis of mantle cell lymphoma. The results have never been fully explained, even though I've tried asking. In a recent phone consultation, I was asked whether I'm mutated or unmutated, and the clinician said she hadn't time to look up the results and explained during our phone conversation. I understand a stage A with stable blood work, I'm not a priority, but on the other hand, I would like to know. Maybe that has kind of been touched on already. Is there anything else to be added?
I think there's a communication issue there with the treating team, really, and I would encourage anyone that feels not listened to or that they haven't had that, the opportunity to ask those questions or have them addressed to ask louder.
Yeah. Okay.
I'm wanting to be empowered, and I read in the brochure that it's 5% family history, it's an age, increasing age, it's a gender, and there's 20 genes that are identified that predispose somebody to CLL, which I have. So I'm just interested to know, in all of the information that we've had today, what is it that we can do without having treatment and waiting? Because the conversation is about delaying treatment, or are you actually prevented? We're not an algorithm like a statin, the NHS and so on. Just wanting to know exactly what I'm supposed to do if I'm not going to have treatment.
Eat your greens.
Well, I was going to say something along those lines, I guess, really. So I think Moira's touched on this as well. It's about keeping well, and Andy said it too, about keeping well and keeping healthy, because it is hard, because people will say to us all the time, what can I do? And really that's the answer to that question, is that staying well, looking after yourself, moderate exercise, not exhausting yourself, lowering your stress levels. I guess all the things that we all need to do anyway for a long and healthy life. But I guess alongside that, and that's a harder bit, is kind of the mental side of this, isn't it? It's how do you get your head around this, and how do you bring it into your new normal, and you go ahead with it. And like Moira said, it's the unwanted guest, so you have to manage that guest and make it fit the box that you need it to fit into. And I guess that's different for everybody, isn't it? And it depends on your own resilience and resources and the support you've got around you as well. And there'll be people that will tell everyone and will want lots of support, and will also, or certainly I will have met people who don't really want anyone to know about this, because they see that if they have that dialogue with people will see them differently, they'll treat them differently. Then the disease is present all the time, because it changes the way that other people look at you, because you're that person with cancer now. You're not Ted, you're Ted with cancer. You know, it changes the way that you are. So I think it's got huge implications for the way that you live your life, and I think it's different for everybody. And I appreciate that's quite wishy-washy, but I genuinely think that I think it differs person on person, really.
Yes, I think you're absolutely right, Jane. And I think one of the things, when I speak to folk, and I know I can sort of like, I don't stand back and hide my cancer, or the cancer. It has a small C in my book. And I say, well, I've got a blood cancer. And they go, oh, gosh, you look so well. And I think a lot of people may have had that said to them, and I very often ask myself, what does cancer look like? Well, maybe it just looks like you on the day and the way that you feel. And, there might be the odd day when you just feel pretty rubbish about it. I mean, rubbish about it maybe mentally rather than physiologically. But, it's it's there. And, you've just got to, accept the fact that, it is there. But don't let it take you over. Try and be in control of it. And the other question that was asked before about the person who wasn't getting the answers when they wanted the answers when they were phoning up, I say, whoa, take that control back. Don't let... no one has the right to be fully in control. So, if with a case like that is you are having the control taken away from you, and you are the patient, and you are the most important thing in all of this. So if you feel that, you're not getting those answers, or you're not feeling the way you should be feeling in the way you're being treated, then take the control back, and remember, information is power, and power is information.
And I think you said before as well, Moira, sometimes it's about asking for that second opinion, isn't it? If you're not happy where you are, don't stay where you are. Go somewhere else. There's plenty of other centres, so move. It might mean a bit more travelling, but if you're going to be happier and you get better care, go somewhere else. Don't stay if you don't want to.
Absolutely right, Jane. And clinicians, they don't mind you doing that. They're not going to fight you. As a matter of fact, Dr. Dasgupta at the other hospital I went to, and who's since been an intermediary in looking after me when I've been in hospital over the water with Prof and Jane. They will assist you in doing that. If they're worth any salt, they really will. But they will assist you in doing that. So don't be, if you feel you're not getting the right treatment and it's not right for you and you're not in that right place, you've got to be numero uno. You've got to look after yourself, and you've got to say, well, stop right there again, stop again, and and try and go into another direction.
And you can do that through the GP as well. That's the other thing, isn't it? If you feel you can't ask that consultant or that team, then just ask your GP to write to somebody different. You don't even have to get that permission off that. It's not permission anyway, is it? But you don't have to get that permission off your treating team. Just take another route.
I think it's important to understand these days there's a lot of kind of clinical networking that goes on between hospitals, not just within hospitals, but between hospitals. And so I think another sort of question you could ask if you feel that, you know, that you're not being given the sort of answers you were hoping for or expected were to, you know, just ask about what the sort of networking situation is for and we have these things called multidisciplinary team meetings where patients with a new diagnosis are meant to be discussed and so on. So those structures and mechanisms can be exploited for the reasons we've just outlined, for the purposes we've outlined.
I think the early intervention, as you've mentioned, multidisciplinary, as a psychologist, that's exactly what we do. So that was probably part of the basis of my question, is that when we're actually waiting, we're waiting for treatment. We're not being treated from the minute we've been diagnosed. That just seems not right for me. It is not right. But there's nothing I can do about it.
It's fully counterintuitive. I agree. Unfortunately, it's where the data takes us. So you've got that kind of conflict there between what feels intuitively wrong and what's evidence-based.
I think coping with that concept is probably one of the earliest challenges, and we try and within CLL Support, Support Act helps people to understand the mixed emotions they feel with regard to that apparent that contradiction, and advocate an active lifestyle. Not necessarily people running marathons or climbing Everest or anything like that, but an active lifestyle within your own capability. So you pick whatever activity. And if those of you might remember what we did last September during Blood Cancer Awareness Month, we canvassed our members for examples of how their coping strategies are. And we got such a diverse response, from people doing gardening to baking for grandkids to, cycling, walking with the dogs on the beach and things like that. And, you don't have to dwell on your CLL. You can live well within certain boundaries with your CLL. And, I suppose the saying goes, everything in moderation except moderation. So, another question from the floor?
I'm quite new to CLL, and one of the things that has terrified me the most is the idea of secondary cancers. And I went on one website forum and somebody had written that skin cancer is practically par for the course when you have CLL, which scared me to death. And I'm just wondering, is that an exaggeration? How much should I be worrying about secondary cancers? Because that's terrified me more than the CLL diagnosis. I mean, I literally turned into a vampire for a week and wouldn't go out in the sun, I just wondered what your thoughts were about that.
Great question about secondary cancers. So I think it's mainly in the context of treatment that it becomes very important, especially in the past we've been using a lot of chemotherapy drugs, and that can be associated with secondary cancers that can develop. So I think it depends on the context of the disease and where you are in terms of treatment, etc. That could affect it. Perhaps I pass on to Prof about the actual underlying risk of skin cancers.
Yeah, so I think with skin cancers, it's important to realise there are kind of two types. There's melanoma and everything else. Melanoma is really serious, although nowadays they've got fantastic treatments for it, actually. The other type of what's so-called non-melanoma or squamous cell or basal cell carcinoma is really, really common. In fact, when we were, and it has a really, it hardly ever turns nasty, if you like, and metastasizes, and it can be, dealt with very effectively just by local treatment on the skin. And in fact, when we were originally trying to get data from NHS England for our real-world study, Uncover. We actually asked for what we call a control cohort. So we wanted to look at blood cancer, but we wanted another cohort of patients, another group of patients that we could compare the blood cancer patients with, who are relatively, let's call them normal, implying that you guys are all abnormal. But health, let's call it healthy, right? Healthy individuals. And of course, in a cancer data set, that's quite hard to find. But the closest we could come to it was patients with non-melanoma skin cancer. Okay, so we were trying to get hold of this other group of patients as the healthy controls for our blood cancer population, which obviously strongly implies that the skin cancer from a prognosis point of view and from a sort of biology point of view is relatively trivial compared to having CLL. So it's really, really common. The risk is a bit higher in CLL, but you have to do really massive studies to prove that. So it's not a kind of huge difference in risk, and it's eminently treatable. So I would, I can understand your concerns. I think I would urge you to try and sort of contextualise them in what I've just said.
We've got a number of supporters or partners in the group today, so if they'd like to ask a question, we'd really welcome them. So, but in the meantime, Nora has put her hand up.
I had a question. Thank you. Just on that topic of secondary cancers, do people with CLL often end up with bowel cancer? Is that something that shows up on your radars? Like the skin cancer comes along? Does bowel cancer come along?
A lot of bowel cancer in CLL, but bowel cancer is really common. And we see a lot of it in people that don't have CLL. Whether there's a slight increase in CLL, I'm not sure. There might be, but I don't think it's such a very common cancer that it's hard to prove that it's any higher in CLL. And I would just urge everybody to engage in the screening programs, the same as you would if you didn't have CLL.
Great, thank you.
One of the things that we're trying to do with the Uncover project is actually to look at the secondary cancers and understand what is the actual burden and compare it to healthy controls, as Prof mentioned. So that might be, we just have to look at the practicalities of how that's recorded, but that's certainly something that we want to actively look into.
Okay, thank you.
I think it's that kind of study the really big numbers. You absolutely need those big numbers to show relatively small risk increases at the population level. So that's one of the strengths of our data set. Yeah.
I would like to see closer working with the mental health teams, because one of the questions posed earlier was the psychological, emotional impact. And that isn't just the patient themselves. I mean, you people do a wonderful job seeing to them and their problem, their body, but it affects everyone. It affects everyone within the family, the friendship circles, and there doesn't seem to be any support or even recognition of that, other than if partners obviously come to the appointments. But still, there isn't anything attached to it. It's sort of like you have your half hour, whatever, and then you go off for however long and deal with it.
I think it might be a little bit centre dependent, but we have a patient support group for patients and relatives that hopefully plugs a little bit of that gap. And then things like the CLL Support Association are here in that area as well. But I think that would depend on the area that you're being treated. So,
And it's a regular thing that crops up in various discussions like this that we get, and what Lewis has said is very appropriate. We can't solve it all. There is clearly a good system in place here in Liverpool, but we know that geographically across England and certainly across the devolved nations, there isn't that support. So the likes of Maggie's and Macmillan, and there may be some very localised services available, but they're essential in this whole landscape of how we try and cope with it. So yeah, I think very important point you just made.
Can I just say, can you hear me? Yes? Completely the opposite for me, because I feel I've been treated as well as my husband has. I was very upset when I found out, and the hospital just referred me straight on. You said, come on, there's somebody who can look after you. And I was referred on, wasn't I, to, for psychological help. And I just found that it wasn't a case that it was the patient and nobody else was cared for. It was, we're a team, and we were treated as a team. So whether I've just been extremely lucky, I don't know, but I have no questions about it.
Well taken, because we know that, for example, with dementia, there's a very well recognized need for carer respite, albeit a different disease completely and different implications. This type of thought process perhaps is not as prevalent in the cancer setting of how it impacts relatives, not just the partners, but as you said, children, and could even be the wider family. So I think having these discussions first raises awareness about the need for it, and then the services available as already highlighted. But that perhaps we need to work more at it to continue to improve it.
Yeah, maybe I can chip in as well. I think when as a clinician seeing a patient, you keep half an eye on the family and have a perception of how things are in terms of the need for support, but sometimes you get it wrong. So I think it's up to not just patients to speak up if they have concerns or issues, but also family. And I would strongly encourage family members who feel in any way unsupported that they should express how they feel, explicitly. So us on the other side of the desk can do our best to deal with it. It's easy to overlook, and I hold my hands up. I've probably overlooked it here, but I think patients can help by drawing our attention to issues, anxiety issues relating not just to the patient but to the family too.
Is CLL a relatively modern disease? And when was the first case identified, and by who?
Yeah.
Can't probably answer it very specifically in terms of the history of it.
Yeah, true.
Due to lack of knowledge. But I think it's a question with all cancers, really. Is it a new phenomenon, or has it always been there but never recognized? Yeah. Or is it a new phenomenon because of the environment that we live in, environmental factors, the exposures that we're getting? So I think that's a very interesting area of discussion and research, and it's very difficult to unpick because the facilities that we have in terms of diagnostics and whatnot, which was not available perhaps 100 years ago, 200 years ago, if those were available then, would we be picking these things up? Is a very difficult question to answer. And I'm not sure, I don't know if you found anything on Google. Who was the first person to...
Look yourselves, yeah, you can look yourselves. 1749, there you go.
Wow. Okay, so another question came in. A question I've asked my medical team, and this person was diagnosed last year and is currently on watch and wait, but they've been unable to answer. When and why does CLL prove fatal? Bit of a sensitive question, but let's take all aspects of it.
So I think there's two reasons really. One is the kind of tumour burden concept. So if you have cancer, any form of cancer, and it grows too much, it can just stop the rest of the body from working properly. It squashes things and so on, or builds up in the blood to an extent that stops the blood from pumping around the body effectively. Most often, however, it's not so much the CLL itself, but it's often kind of failure of the normal immune system, and that often goes along with the CLL being uncontrolled as well. There's often a kind of reciprocal relationship there between the CLL and the immune system working properly. So yeah, it's really, you know, failure of the immune system or the bone marrow as well. If the bone marrow is not making normal blood cells as well as it ought to, then you know, in an extreme situation, that can prove fatal. So there are several potential explanations, and often it's a mixture of more than one thing, really. Anything to add to that?
And I guess, so the question is, when does it become fatal, and was it what? How?
Why, yeah.
Why? So I guess it really depends on also the anatomical, so by anatomical I mean where's the disease located. So some people may present with big lymph nodes, whereas others don't have any and they just have a high lymphocyte count, which the GP just picked up incidentally. So everyone's disease is different. So if you have very large lymph nodes, it depends on where they are, whether they're causing, having a pressure effect on other organs. And so at that point, that might become relevant in that patient's journey and in terms of requiring treatment. If it's more in the bone marrow where you can't see it, but you can see it in the bloods where your counts are a bit lower, your hemoglobin is dropping or your platelets are lower, then again, that's a different scenario, and that can lead to related complications associated with lower blood counts. So it really depends on what the disease course is, which part of it is it affecting you, that then this can then give us an idea of how it affects you and how then it needs to be treated, essentially.
Thank you. Any more questions from the floor? John.
There's obviously been huge strides made in understanding CLL and its treatment, but what, if any, are the big unknowns about either CLL itself or about the treatment of CLL, as far as you're concerned?
I guess I'm coming from a very sort of biased perspective, having done my PhD in drug resistance. And I think that's an area that cancer is very, very clever in simple terms. And although we are coming up with newer treatments, we are finding that there are resistance to those treatments as well, even with ibrutinib and venetoclax, etc. So I think that this is an area which will always be requiring more and more research, understanding, as we come up with more newer treatments, as some of the treatments Dr. Williams was referring to earlier, as they come to market, we'll start to realize that actually not all patients are responding to them, and try and understand why that is happening is going to be an area of ongoing research. And it's going to be drug specific, most likely. Although P53, as Prof mentioned, usually has can be applied to everything. And actually we know with the ibrutinib data that if you have P53, then that may have implications of your response longer term. But we will be coming up with more specific things in terms of why this patient has developed resistance to this particular drug, and that will be an ongoing area of research. And as newer drugs come up, more things will come up. And it also goes down to the way that the CLL cells are in your body. They constantly evolve over time. So even though you have given effective treatment, they may come down to a very low level, but then for whatever reason, they may be triggered and then start to then grow again, and they may stop responding to treatment. And so this type of area of how that dynamic works and what causes the evolution to happen is, I think, a very hot area of research.
I agree. I think there's also the issue of, you know, this what we call stem cell. Well, what's the CLL stem cell? What does that look like? How can we target it? Because probably what we're doing with the treatment is we're killing cells we can see, but maybe not. It's like sort of weeds. You know, you're pulling the weeds out, but you've still got the roots behind, and then it sort of grows back again. So for me, one of the questions is how can we pull the roots out, not just make the garden look pretty, because we sort of chop the weeds off at the stem. The other interest, I think, is understanding the immune system in CLL, and in particular, I mean, the holy grail is how can we kind of repair the immune system? That's one thing. How can we kind of use the immune system to attack the CLL? Can we kind of subvert it? Can we trick the immune system into killing the bad guys? So I think those are two particularly interesting and fertile areas for research. And I suppose the third thing is we've got this kind of pipeline of fantastic new science going on. You know, techniques we could only have dreamt of, 10 years ago. You know, the ability to sequence, look at every base in the whole genome. You know, the human genome goes to the sun and back. You know. And we can sort of measure it all. It's just incredible. And we've only really scratched the surface in terms of harnessing all that scientific potential to kind of tackle the fundamental problems. So I think there's this kind of translation gap, you know, harnessing all this fantastic science and using it to address the fundamental challenges in CLL.
I think a very interesting area to add on to that is the differences that we see in response and the side effects that patients experience. So you may have two identical patients on paper, but they may have very different experience of the treatment. One may experience lots of side effects and the other doesn't, and the outcome or the response may be very different. Why is that? Are they processing the drug differently? Is their genetic makeup different? And that's an area which I think has been relatively unexplored so far in the field of CLL, at least.
It used to be that stem cell transplant was quite a regular within the area we're talking about option, and then T-cell was talked about as being the holy grail, and that's no longer necessarily the case. Can you just sort of talk about that for a minute, because we're coming close to our wash-up time, so.
Yeah, so I think so a donor transplant is the type of transplant that was previously, so like an allogeneic stem cell transplant was previously utilised in patients with aggressive disease courses, and I only know of one patient that's gone through that during my time as a haematologist. So certainly not utilised now, but and that's really just in the context of such good treatments being available and for first line, but also for second and subsequent lines of therapy. And CAR-T, the current kind of data is not as impressive as initially felt, but I think there's still some interest in re-looking at it. And so that might come in the future. So there's still people talking about it and how, but the kind of companies that are doing the trials or looking at CAR-T therapy are slightly less interested in CLL at the moment.
Thank you very much, panel, for handling all those diverse questions.